Okay, so welcome everyone. Today we are going to be discussing a very short lecture on shoulder examination. So we were also planning to do something on X-rays and poke of the shoulder, but that will be postponed to some other time because of some technical difficulties and the people not being available. So without further delay, I think I will hand it over to Salik to take over with the presentation.
Hello, good evening, everyone. I'll be discussing some 20 to 25 slides on shoulder examination. Initially, we'll be going through some basic anatomy, just the required part. After that, we'll be going through some general aspects of shoulder examination, followed by some specific examination for targeted to specific pathologies. So first of all, starting, it has everything. The shoulder joint has everything. So it has its bony bones. It has its
Salik, your voice is not clear. Can you please speak a
am I
little
clear now?
louder?
Is it
Yeah,
clear
yeah,
now?
yeah,
Okay,
yeah.
okay. So first of all, the bones. So we have three major bones which we look for: the clavicle, the scapula, and the humerus. Similarly, the joint, we have four major joints. The joint near the sternum and the clavicle, the sternoclavicular joint, the acromioclavicular joint, and the glenohumeral joint. And there is a pseudo joint also, that is the scapulothoracic joint. So similarly, tendons, we have the tendons that form the joint capsule, the tendons between the bones like the acromion and the coracoid process, the trapezoid ligament, the conoid ligament, all those things. Similarly, we have, the ligaments. And similarly, we have tendons that connect the muscles to the bones like the biceps tendon. Only the biceps tendon is somewhat significant here in our shoulder examination. Similarly, the major muscles which constitute mainly the rotator cuff muscles and the deltoid we have. So the rotator cuff muscle, supraspinatus and infraspinatus and teres minor will be posterior to our scapula, and anteriorly we have that subscapularis muscle. Similarly, covering, encasing the whole structure, we have the deltoid muscle as well. And quickly through the nerves also, medially we have three major nerves that is supplying our forearm. Most medially we have the ulnar nerve, then we have the medial nerve, and laterally going we have the radial nerve. But what nerve is more important is the axillary nerve, because axillary nerve can be associated with the pathologies associated with the shoulder joint. We'll be going to the general aspects of shoulder examination. We'll be starting with inspection. But before going into specific inspection, we should always keep in mind that for any inspection of shoulder, the patient should be stripped of, above the waist. That is, his shirt should be taken off. And every time we should compare bilaterally. We should always compare bilaterally. If you're suspecting pathology on a particular side, we should always look symmetry and everything. That will give us clinical insights. So starting with the inspection. So the way the patient comes to us in our clinic itself will give us some clues about what pathology we are dealing with. For example, if the patient comes supporting his injured part in a flexed elbow using the healthy arm, it can be either because of a clavicle fracture, or it could be because of a dislocation of the shoulder, anterior dislocation of the shoulder. So that is very important. For after that, we have to look for any deformities or swelling that is that we are able to appreciate by inspection. So along the length of the clavicle, we have to look for any swelling or any redness or anything. Usually we'll get at the point of the medial 2/3 and lateral 1/3, which is more prone to any fracture or anything. Similarly, any dislocation of acromioclavicular or sternoclavicular joint, if there is acromioclavicular dislocation near the sternal end, acromioclavicular dislocation, the lateral side, there will be swelling or deformity. Similarly, sternoclavicular will have in the medial side. Similarly, subcoracoid dislocation of the shoulder, that is the arm is dislocated subcoracoid. So there will be similarly in the deltopectoral groove, there can be swelling, or the contour of the shoulder, there can be flattened shoulder, or the acromion process will be since the arm is dislocated subcoracoid, the acromion.
Difficult for me to change my perception over the front.
Excuse me, ma'am. Can you please repeat? Hello.
You can continue. I think that is background noise.
Okay, so the acromion process might also be prominent on inspection. Similarly, if there is a neck of scapula fracture, which is hard to pick up on inspection and palpation, but what relatively these findings can be common in other pathologies also. So it is not very specific, but any drooping of shoulder and lengthening of arm, drooping of shoulder associated with lengthening of arm, we should start thinking about any neck of scapula fracture associated with a pre-existing clinical context of injury or whatsoever. So next in inspection, so initially we check that the attitude, then we look for any deformities or swelling. Then the most important is the contour of the shoulder. So if there is any dislocation, mostly we'll be getting any flattening of the shoulder, or there will be any, that roundness will be lost. So similarly in the axillary folds, we'll be able to visualize. Suppose the subcoracoid dislocation of the shoulder, the humerus will be displaced subcoracoidally. So there will be, in subcoracoid dislocation of shoulder, there can be lowering of anterior axillary fold. Similarly, in neck of humerus fracture, we will be able to appreciate a swelling in the shoulder region, but there will not be associated loss of roundness. So, like neck of humerus fracture versus dislocation, if we are going through that, then we may look for that loss of roundness. There won't be any loss of roundness, but there will be swelling. Similarly, during inspection, we should inspect all the bony arches. Like we should be looking at the clavicle, the acromion, the spine of scapula, all the prominent bony arches, the subcutaneous portion of the bones should be examined during inspection. Palpation will be going with individual bones. So first of all, clavicle. So patient is made to sit on a stool or something with his upper body exposed, and the examiner stands behind the patient. And then he starts to examine from medial, bilaterally, from medial to the lateral. So what we are trying to look for is any break in line in continuity, or any tenderness, or any crepitus that we are going to look for, or any abnormal prominence. So common dislocation associated with the clavicle, that is either it can be a sternoclavicular dislocation, or it can have a acromioclavicular dislocation. So in sternoclavicular dislocation, what usually happens is the sternal end of the clavicle will be displaced anteriorly. So if you are able to appreciate an anterior projection in the sternoclavicular projection location, we should suspect sternoclavicular dislocation. Similarly, if there is an acromioclavicular dislocation, what happens is the acromial end of the clavicle will be subluxated upward. You will feel a prominence here. So during clavicle examination, these findings suggest of dislocation. Next, we will be going through humerus. So how to go about it? Similarly, same position, we stand behind the patient. We start from the acromion process. Once we palpate the acromion process, then we go laterally, and we try to palpate the greater tuberosity. So usually there will be a bump or a resistance between that acromion process and the greater tuberosity. If we are not able to appreciate that greater tuberosity, or there is no resistance, that it is a smooth, then it is suggestive of dislocation of the shoulder. And similarly, while going down after palpating the greater tuberosity, we should ideally extend it going down till the shaft. And in this area, anywhere near the surgical neck of the humerus, or in the shaft of the humerus, if you are able to elicit any crepitations or any pain or tenderness, that is suggestive of fracture of that area. Next thing to keep in mind in humerus is that there is a bony relation. That is, the medial epicondyle will correspond to the head of the humerus, and the lateral epicondyle will correspond to the greater tuberosity of the humerus. So if there is any disruption in this so-called bony relation, that is suggestive of a fracture in between these two bony points. It can be fracture, it can be below the neck or anywhere. And in suppose we are dealing with a fracture dislocation and not purely dislocation, there is what we can do is keep the patient arm in a flex position, and we can try rotating the arm, internal or external rotating the arm. If there is suppose that is in a patient we are suspecting dislocation, and if we want to look if there is any added fracture in dislocation superimposed with the dislocation, then look for transmitted rotation. If there is no transmitted rotation, that means there is a break in the shaft of the humerus or anywhere, or if there is any crepitations that is elicited during the movement, that is also suggestive of this. Similarly, while palpating, if below the acromion we are able to feel any tenderness, it can be because of any local pathology like greater tuberosity fracture because of any local trauma or any supraspinatus tendon. Similarly, scapula, we should palpate all parts of the scapula, starting from the spine, from the acromion process, then from both the borders, vertebral and axillary border and inferior angle of scapula. it is easier to palpate the subcutaneous areas, but the areas which are below the muscles are usually difficult to palpate. But we can always compare bilaterally for any pain or tenderness or any defect in the continuity of the bone. Similarly, we should also be palpating for the coracoid, which will be found half an inch approximately below the clavicles fracture point, medial two-third and lateral one-third of the clavicle. So one thing which you should be careful is neck of scapula fracture. So what the issue is, similar to neck of scapula fracture, the upper end of humerus fracture also, everything presents with a diffuse swelling and pain over that area. It is kind of hard to distinguish between is it a neck of scapula fracture or an upper end of humerus fracture. So one examination modality that can be used in this setting is that suppose the patient presents with a drooped shoulder, and we are able to elicit a tenderness or crepitus by axial pressure upward. Then that is suggestive of neck of scapula fracture. Or if you are able to carefully examine the patient, that is lateral to the glenoid cavity, you won't be able to feel any tenderness, but medial to the glenoid cavity, you will be able to feel tenderness. So all these features are suggestive of neck of scapula fracture. Similarly, one more bony point relation that is relevant in shoulder is the 3-point bony relation of coracoid process, the acromial end of the clavicle, and the greater tuberosity. So what we should be doing is we should compare with the healthy side. If both sides are equal, more or less it will be normal. But suppose we have a acromioclavicular dislocation, then what happens at the clavicular end of the what happens at the end of the clavicle is that it will become more prominent and it will come closer to the greater tuberosity and away from the coracoid process. So these things are suggestive of any acromioclavicular joint dislocation. So this was all about palpation. So we have gone through inspection, general palpation of major bones. Now, one thing is measurements. Various measurements are done during examination of shoulder, mainly the length of the arm and the vertical circumference of the axilla. So length of the arm. So where should we be measuring? We should be measuring from the acromion angle, that is where the spine of the scapula turns in and becomes that acromion process. From that angle to the lateral epicondyle, we should be measuring. The importance is not of the absolute value, but rather comparing with bilaterally, like looking for any lengthening, any relative lengthening or shortening of the distance with respect to the healthy side. So usually in case of neck of humerus fracture or there is a subcoracoid dislocation, the length of arm is usually shortened. Similarly, if there is a subglenoid dislocation or there is a neck of scapula fracture, then we'll have a lengthened arm. Similarly, for dislocation, one thing we can do is vertical circumference of the axilla can be measured. And it will be increased in case of any dislocation, but it can also be increased in case of any upper end of humerus fracture or neck of scapula fracture. It is not very sensitive, but it will tell us that something is wrong and that we should be getting an X-ray for the patient. Similarly, this is same as Briand test, where there will be a lowering of anterior or posterior axillary fold that is associated with the dislocation. And one common test which we can do to look for dislocation is the Hamilton ruler test, where we take a ruler or any straight surface and we keep it, we try to align it with the acromion process and the lateral epicondyle. In healthy people, what happens is that we won't be able to align those two things because the greater tuberosity comes in between. But in dislocation of the shoulder, it is displaced medially so that it becomes straight and we are able to connect both the acromion process and the lateral epicondyle with a straight surface. So the Hamilton ruler test will help us look for any dislocation. After measurements, the other domain in examination is movements. So any patient that is coming to you with any shoulder pain or any difficulty, you should elicit complete range of motion. So initially, forward flexion should be done. We should do forward flexion and extension. Similarly, abduction of the arm and crossbody adduction should be done. Similarly, internal rotation, external rotation and internal rotation should also be tested. So all these range of motion should be tested. What we should be doing is looking for is symmetry of movement between both the sides. And at the same time, during this motion, we should visualize the scapula from behind as well to look for any asymmetry in the motion of scapula. That is also suggestive of any pathology. Similarly, Dugas test, which is very commonly used test to look for shoulder dislocation. What we ask the patient to do is we ask the patient to touch the opposite shoulder using the affected side, and his arm should be in contact with the chest wall. So if the patient is in shoulder dislocation, the patient will not be able to touch the opposite shoulder. And the Dugas test or this position is should be kept and maintained after reduction, or after post reduction we can check for Dugas test again, and it can give us an idea of is the joint reduced, or about an idea about the extent of reduction. Similarly, that position is maintained in the post reduction period for post reduction. Quickly about nerve complication associated with shoulder injury. So one thing we should look out for is only axillary nerve injury. The other things can be protected because of the axillary cushion and fat pad and everything, the medial radial nerve, but the axillary nerve can be commonly injured. So one easy thing what we can look for is over the lower part of the deltoid, there will be loss of sensation of skin. There's a cutaneous branch of axillary nerve that's supplying that area. Or there can be a limitation of shoulder abduction, that is that midway period from the 15 to the 90-degree area. There can be limitation of shoulder abduction. These things should give us suspicion about axillary nerve injury. These are the general aspects of examination of shoulder. Next, we will be going through some specific pathologies associated with shoulder and how to go about examining those specific things. So first, I will be going through rotator cuff injuries. We will be discussing it as 4 muscles that is involved in the rotator cuff. So first of all, we'll be going through supraspinatus. So for each testing each muscle, we'll be keeping the hands in a particular position, and we'll be checking for power, pain, and everything in that particular position. So for supraspinatus, in the 90-degree like you can see in the image, in the 90-degree abducted and 30-degree forward flex position. In that position, we check for power. We give downward pressure to the both arms, and if there is any reduction in power or any difference in power, or there is any pain, that we compare bilaterally. There is any reduction in power bilaterally, or there is any pain on particular side, that is suggestive of involvement of supraspinatus. Similarly, from this position, what we can try to do is ask the patient to imitate the motion of emptying a can. And emptying a can, if the patient has difficulty in doing that, there is pain associated with it. Or after that position also, you again check for pain and power bilaterally. If there is any abnormality during this, that is also suggestive of supraspinatus injury. Similarly, infraspinal and terespinalis are tested together. So just opposite way. You keep the patient's arm in that elbow flex position, 30-degree in this position, and you give downward pressure, like you can see in the image. You give downward pressure. Similarly, you compare for power bilaterally and pain. For all examination, it is comparing power and pain bilaterally, and any abnormality should lead us to do an X-ray and further evaluation. Not X-ray, further evaluation. Similarly, subscapularis is the 4th muscle. So the position, what you can see in the first image, that you ask the patient, you take the patient's arm to that position, and you ask the patient to maintain that position. If the patient is able to maintain that position, that is, his hand is not touching his back, then that means his subscapularis is healthy. But if the patient is not able to maintain that position, and his hand goes and touches his back, which is called an internal rotation lag sign, that is suggestive of subscapularis. Or otherwise, you can also check power of subscapularis, which is called Gerber's lift-off test. In the same position, you give a pressure against his back, and the patient tries to resist the pressure. So if in a healthy subscapularis, the Gerber's lift-off test, he'll be able to apply pressure. It won't go and touch his back. And even though the serratus anterior is not part of a shoulder rotator cuff, we usually examine that along with the rotator cuff muscles. So we ask to do a standing push-up against a wall or against resistance, and we look for any wiggling of scapula that should suggest of associated serratus anterior pathology. This is about examination of muscles associated with the rotator cuff. Next is impingement of supraspinatus, that is shoulder impingement. So in this, we have 3 tests that we can look for to look for any shoulder impingement. So the empty can test, which we have already done, that was during supraspinatus examination. You ask the patient to empty the can, the motion imitating emptying a can, and then you look for tenderness or any pain in the area of supraspinatus. Similarly, Hawkins-Kennedy test, what we will do is we do a combination of internal rotation and cross-body adduction. That is, in this position, we'll keep internally rotating the hand. At the same time, we'll keep adducting the arm towards the opposite side. So as it comes closer, it will impinge on the supraspinatus and it again can cause pain. Or while examination, we can find any tenderness or the anterior shoulder line, or there is any scapular movement asymmetry. If you are able to find any scapular movement asymmetry, that should also suggest of supraspinatus. Next, going into biceps tendinitis. So any tendinitis of the biceps, as you can see in the image, we have the proximal and the distal end. So we have the Speed's test and the Yergason's test that is used to look for any biceps tendinitis. So in Speed's test, as you can see in this image, what you want to do is you resist forward flexion, and at the same during the time you are resisting the forward flexion, you palpate the tendons, the proximal and distal tendons, and you look for any tenderness or pain. Similarly, Yergason test also, you hold the patient's hand and you ask them to supinate and you resist the motion. While you are resisting the supination, you palpate for the tendons, the distal and the proximal tendons, and any pain or tenderness should suggest of any biceps tendinitis. Next, going into frozen shoulder, also known as adhesive capsulitis. The patient's clinical history, they will tell initially it started with pain in the shoulder, and then there will be restriction in range of motion. Both active and passive range of motion will be restricted. So while examining a range of motion, what we can see is there can be limitation of external rotation, which is the first movement to be affected. And the frozen shoulder, because of the pain associated with that side, there can be scapular asymmetry. And if you are examining the, if you are palpating the trapezius of patient suspected frozen shoulder, what we can see is there will be painful points or muscle spasm. The trigger points and muscle spasm in trapezius secondary to the frozen shoulder of that side. Similarly, in any acromioclavicular joint pathology, not trauma or anything, the patient will either have localized pain or patient will have night pain, because if the patient is lying down on that affected side, then he can have night pain. What we should be doing is we will palpate the joint, from the clavicle will palpate. If you are able to feel the continuity, then it is okay. But if there is any step of deformity, that is suggestive of any acromioclavicular joint pathology. Similarly, scarf test. Okay, images there. The scarf test, that is just a cross-arm adduction test. So as you can see in the image, you keep in that position and you give pressure. So if any pain or crepitus in the and you palpate the acromioclavicular joint while this motion is being performed. And if any pain or crepitations in the acromioclavicular joint, that is suggestive of any acromioclavicular joint pathology. Similarly, in the overhead abduction, that is in the 150 to 180 range abduction, there can be a painful arc. That is also suggestive of acromioclavicular joint pathology. Next is shoulder instability. So any patient, it can be acute or it can be chronic. In chronic, there can be hyperlaxity or recurrent subluxation. So examination finding, one thing is sulcus sign. That is, you apply a downward force on the arm that is suspected, and you are able to appreciate a sulcus or the lateral deltoid region, like you can see in this image. You apply a downward pressure and you look for any appearance of sulcus there. That is suggestive of any shoulder dislocation. Similarly, apprehension and relocation test. In this, as you can see in this image, you make the patient supine, then you use your hand as a fulcrum behind the affected shoulder, and first you apply pressure downwards. So this simulates dislocation. That is, patient symptom will worsen. They will complain of pain and anything. And after that, then you you are applying pressure over the lateral, so that you are displacing the shoulder anteriorly. After that, after eliciting the pain, you go and try to reduce the shoulder. That is, you apply downward pressure over the shoulder, and the patient would say that there is a relief of symptom, or patient will feel better. So that is also suggestive of shoulder instability. And Dugas test we have already discussed. Try to test the opposite side, that patient won't be able to touch in case of shoulder instability. The last thing which I would be discussing is labral tears or SLAP lesion. So SLAP lesion is nothing but the glenoid labrum's superior labral tears. which can happen in athletes or because of any road traffic incidents or anything. So during palpation, you can see there will be a joint line, the anterior joint line fullness can be present. There can be loss of power, etc. But three tests which we can be doing is one is speed test, just like biceps. You in the forward flex position, you apply pressure. So you will have a pain in the proximal insertion point of the bicep in the labral area. The reason being the biceps tendon inserts on the superior portion of the labrum. So any pressure or any tension in the biceps should transmit the pain there. Or we have O'Brien's test. That is, you keep the hand in the flex position and you apply downward pressure. In speed test, you are keeping it in normal position and you're flexing the elbow and then you're applying the resistance. In O'Brien's test, you are flexing the shoulder and then you're applying a downward pressure. That will also elicit pain or any tenderness that is suggestive of any labral tears. Similarly, there is crank test. That is, you alternate between internal and external rotation. That should also elicit any pain or tenderness if there is any labral tears associated with it. That will be all. Actually, I wanted to discuss some points like while looking at any shoulder examination or any shoulder pathology, we should always see in the clinical context. Like suppose the patient presents with a fall on the shoulder. And you have a dislocation here. That is the mechanism of injury is very important. That's the point I would like to discuss. Any fall on shoulder, we should start suspecting sternoclavicular injuries, or there is traction of the arm, or there is a fall of weight over the shoulder, we should start suspecting acromioclavicular injuries. Or if there is fall on outstretched hands, depending on clinical presentation, it can be a clavicle fracture, it can be a scapular fracture, it can be dislocation of shoulder, or it can be a neck of humerus fracture. So basically, clinical examination should always be done in context with the clinical history. Is it a trauma? Is it a gradual condition? Is it a chronic condition? Depending on that, we should be able to diagnose. Next, sir, that will be all. Hello? Hello?
Salik, so that was a very nice presentation. It was I think you were very thorough in how you presented today. So I don't think there is that much to add. One or two, just a few tips that I would like to say. As like you said, it's very whenever a patient is coming with you with shoulder pain outside of a trauma scenario, and even in the trauma scenario, obviously, but like he said, it's very important to actually expose the shoulder, because you do not want to miss the some kind of rash like herpes zoster on the shoulder just because you didn't expose the patient. So some very rare, it's rare, but sometimes patients can come with that kind of presentation. So you should not be missing that. And another thing is that shoulder pain and patients can sometimes have difficulty in differentiating shoulder pain from neck pain. So if it's not obvious with your examination, so it might be a good idea to actually take a look at the neck also for any pathology. Srideva ma'am, do you have any other points you would like to add?
Yes, that was again a very good presentation, Sally. So you have almost covered almost all the points. So I would also like to add something. So in trauma settings, always most of the time it's an anterior shoulder dislocation. And in a case of seizures, like if the patient had a seizure, you should always suspect a posterior dislocation. After seizure, if the patient is telling that the patient is not able, it is pretty common. I've seen almost 5 to 6 cases. And then before doing all these examinations for all the joints, you should always check the distal neurovascular status. And after doing all the maneuvers, you should again check the neurovascular status, that because of your doing maneuvers that you have not disturbed the neurovascular status or it has improved or not. And after reduction, again check the neurovascular status. So one thing that I want to stress here is always before and after check the neurovascular status before doing any procedures. This is for any joint. And for posterior dislocation, if the patient is presenting for dislocations, if it is if the patient is presenting for the first time, then you have to get an X-ray before reducing. But if it's a habitual dislocation, if the patient is having recurrent shoulder dislocation, so there is no need for an X-ray. So the patient is coming to you with dislocation third or fourth time, there is no need to get an X-ray before reducing.
Yes, ma'am, very well said. You should never miss the neurovascular status of the limb with any kind of a joint pathology. So, if anybody has any doubt, I think you can ask right now.